Okay. So not only do we have to, talk to our patients about what to expect pre-op and prep and intra-op and all that, but we also have to make sure that they understand what the procedure is going to be after they have their surgery. What do they expect? If you're going to send a patient to intensive care unit after their surgery, they need to know that's where they're going to wake up. Okay? Sometimes that's unplanned, okay, and you'll have the family waiting in their room for them to come back from surgery, and you sent them to the ICU. Okay, so you communicate that and just know that you need to let your families know where their loved one is. But let the patient know if there is a risk that they'll be sent to another unit, especially if they're not going to have access to their family. Okay, let them know what kind of monitoring requirements that we have after surgery. They're going to want to sleep and us leave them alone, but I'm sorry, that's not the way it works. And they need to understand that we're going to be bothering them about every 15 minutes for the first hour or so to get vital signs and to do assessment. That's when they're in the PACU. And then once they get to the floor, we're still going to be aggravating them, okay? They need to know that. They need to know what kind of monitoring equipment we're going to have them hooked up to. Maybe they've got continuous pulse ox, continuous blood pressure. They may have a heart monitor. If we're sending them to the ICU, they can have any number of tubes and things hooked up to them, right? What kind of equipment can they expect? A patient needs to know if they're going to come out of surgery with a drain, a chest tube, any kind of tube running out of any kind of orifice they need to know about, okay? Just knowing that ahead of time and reinforcing that will keep your patient a lot of times from pulling the tube at the tubes and pulling out, okay? If your patient is going to come out of the surgery intubated and on a ventilator, they need to know that, okay? That they will not be able to speak, okay? And there needs to be some form of communication worked out ahead of time so that the patient knows that they have a way that they can communicate with the nurse. If it ain't anything but one of the ding-ding bells like you see at hotels. In the movies, they don't have that anymore. But you know what I'm talking about? Ding-ding, those little bells there aggravate the stew out of you. But that's the way that the patient can communicate that they need something. Sometimes they use those little dry erase boards that patients can write on. But work that out ahead of time. Okay. So they need to know what equipment is there. They need to know about their dietary issues post-op. That we're going to hold them in PO until they have a gag reflex return or until they're awake and alert enough to handle something by mouth. We usually start out with ice chips to make sure that they're not going to aspirate that, okay, before we move on. So they need to know they can't have anything. And that's the first thing that they ask for when they start waking up. I need something to drink. My mouth is so dry. Okay. And then we have to be mean and say, oh, I'm sorry. Okay. We don't hold them in PO quite as long as we used to because they're not hanging with us long. We got to get them out. They got to go to the house. So as soon as they start waking up, we'll try to give them a few little ice chips. If they're tolerating that, then we'll move it on up to something clear. Okay. See if they're, usually it's like 7-Up or something like that we'll give them. See if they can sip on that. If they tolerate that pretty good, then we can move on. Okay. But some patients are not going to be able to eat for a while. They need to know that. Okay. Pain control. What sort of pain control is going to be available to me after surgery? Huh? Morphine. Yay. Yes. It's a lot of your patients will come out from surgery on a PCA pump, patient care analgesia. That's where they get to press the button when they need something for pain, and it automatically doses them. Now, anesthesia in my organization, anesthesia monitors that. They write the order of what the medicine is, how much the patient can have, how often they can have it, and they usually say in a 4-hour period they can't have more than so many milligrams. Okay? So it doesn't matter if the patient is doing this, they're not getting something every time they're doing that. And you will have patients that are doing it. Okay? Did y'all talk about PCA pumps in 102? So you know what I'm talking about. Great. Great. Okay. What is the main thing about PCA pumps that you teach your patient? Exactly. Only they can push it. And you reiterate that when you're doing your pre-op teaching. You reiterate that when your patient comes back to your floor. Okay? You reiterate that with their family. Now, only let him push it. You don't push it for him. Because he can get too much if you push it for him. Now, do people abide by that? No. Well, now that's your husband. That's your husband wanting you quiet. Yeah. They just need to understand. Now, but I will tell you, it's a little bit different when you're the family member. My daddy had surgery, and he would just be doing like this. I'd push your button, Daddy. Push your button, Daddy, because he was not going to be a good patient. So I was like, push that button, Daddy. So I kept him snockered for 2 days. He says, He said, that's why I don't let you go to the hospital with me. So, but I know, but some family members don't. So, I just figured the nurses had rather me have him push that button than him be awake. He wasn't going to do good in that bed that long. So, make sure that we explain to the family why we don't want them pushing. And if they question, call me if you think he needs something, and, I'll come and assess, and that's always better than them overdoing it. There is a lockout, but again, if the patient doesn't need it, the patient doesn't need it. Okay? Patient needs to understand what's available there. They need to know, too, that they're going to have their PCA for only a period of time. We're not sending it home with them, So once we see that, then their options are we'll have pain medicine for you. You just have to ask for it, and you'll be able to get it every so often, and yada, yada, yada. Okay? They need to understand about respiratory care, musculoskeletal care post-op. When we start talking about post-op complications, one of the things we'll talk about is pneumonia, respiratory issues. So our patients need to know that immediately post-op, we're going to start aggravating them to turn, to cough, and to do deep breathing exercises. We're going to demonstrate that to them pre-op, have them practice it, so that when we do kind of jar them awake and say, take a deep breath for me, they kind of can bring back to the front of their mind what I'm talking about. Okay? We've got to get them, by taking those deep breaths, it helps them to blow off anesthesia, and it also helps them to expand their lungs, get good gas exchange, move some of those secretions around in there so we don't get any pooling and pneumonia develop. So we turn them, we make them do deep breathing, and then we make them cough. Okay? Now, coughing in a surgical patient, they hate that. Oh, they hate that. But they have to do it. It helps to expand the alveoli. So, your book, page 256, has got instructions on how to do deep breathing exercises, how to get your patient to cough. They take 3 good, real good deep breaths, and on the third one, they're going to cough. And it's a forceful cough, not a, because that's what they want to do, because it hurts. But it needs to be a cough, okay? Your book also, I think somewhere in there, shows you about having the patient splint their incision, which means putting a pillow across, if they've got a abdominal incision or even a chest incision, splinting it and then doing their cough that way, kind of holding some pressure. Okay, but we've got to make sure they understand that a cough is a cough, not a. Okay. Your patient will be instructed on how to do incentive spirometry. Do you know what that is? I think we talked about that in oxygenation, right? Where they blow into this thing and pull back, and it tells how much volume that they're moving. We have patients do that at least every 2 hours. Ow! Kidney stone or something. Oh, good Lord. If I fall out, okay, y'all help me. Ow! It's not drugs, I promise. It's not drugs. Oh man, I just lost my train of thought. Incentive spirometry. We have patients do that at least every 1 to 2 hours while they're awake. Good lung expansion. Kids, what works well with kids is have them blow up a rubber glove. That works wonders for them. Rather than sucking on that machine, have them blow up a balloon. Have them blow up a rubber glove. Okay? Yeah, not allergic to latex. Good point. Okay? So incentive spirometry, this stuff is vital, guys, for your patients to recover without those respiratory complications. Turn, cough, deep breathe. Use their incentive spirometry at least 1 to 2 hours while they're awake. Sometimes, if they're a really big risk, we're going to wake them up every 2 hours and make them blow in that thing. I'd rather them be mad now than staying with us an extra week because they've got a big case of pneumonia. Okay? Musculoskeletal teaching. Your patients are not allowed to lay in the bed anymore. We get them up, get them moving. Most patients will have surgery, and that evening they're up in the chair to eat. And the next day they're ambulating in the hall. Research shows that the quicker you get them moving, the less respiratory and cardiovascular complications that they have. They will, the purpose is to increase blood flow so that they're not developing clots. Deep vein thrombosis is one of the big risks that you have after surgery. That's some of your skip core measures address that. We put people on prophylactic anticoagulants. If they meet certain criteria, they need to be on those things. Okay. These are on 257, these exercises. Kind of look at those. But we're wanting to get the blood circulating. What else did you learn in 102 that we do to prevent clots? We put TED hose and we put SCDs on them, right? That's pretty standard for just about anybody going to surgery these days, is to put those things on, okay? So your patients need to know that we're going to make them move, we're going to make them get up, and that we're going to make them do some exercises with their legs. They hate it too. Oh, they're sore and they just want to sleep and leave me alone. So we have to kind of be firm but kind and get them out of that bed. Okay? Kids are not happy with that either. Okay? But again, if you take the time pre-op to explain why, it makes your job much easier. Questions on that? Look at those exercises. Okay. You may, yes. The exercise, the leg exercises and the deep breathing exercises. Not jumping jacks. No. No, they really are not going to do no jumping jacks for you. Okay, let's talk about pre-op medications. Y'all know we can't do anything as nurses unless we're giving drugs, right? Pre-op medications may be ordered for your patient because they do these wonderful things here. It promotes the sedation and amnesia, so your patient doesn't remember. Helps to prevent your nausea and vomiting. Decreases secretions, especially respiratory and GI. That's why your patients come out and they're thirsty. We've dried them up. Okay. Decreases their anxiety and apprehension. Helps to start with some pain control. Facilitates the anesthesia. It helps it to work quicker, better, and it decreases the need for as much of it. So your pre-op medicines, not everybody gets that anymore. Used to, everybody got a pre-op, and they got it on the floor, and then the patient went to surgery. But now what happens is your patients usually will go from your unit to the OR and stay in a holding area. Anesthesia may talk to them at that point, so you can't pre-op them, even though I did. You can't pre-op them until they get back there. So a lot of your patients will not have that now, but some still do, especially if you've got somebody who's very, very anxious. Okay, a child, they still a lot of times will get a pre-op. Okay. So it may be ordered. It may be ordered on call to the OR, which means OR will call you and say, pre-op that patient. Or it may be ordered for a specific time. But again, make sure your consent is signed and make sure that anesthesia has seen them. Very important. Okay? So these are some of the types of medications that may be ordered. We'll talk about them. This is the good stuff, right? Sedatives, hypnotics, anxiolytics, opioids, and then they start to get not so fun. Anticholinergics, antiemetics, and then some of your GI meds. Most of your sedatives are narcotics and opioids. We give them pre-op for sedation. Intra-op helps to with the induction of anesthesia, like we talked about. And then post-op, we use them for pain management. Okay. Some of your more common ones that you see out there is Demerol, morphine, and fentanyl. Demerol is not quite as prevalent as it used to be. We use a lot more morphine now. We use a lot more Dilaudid now. Dilaudid's good stuff, yeah. Demerol, it's so amazing. I mean, probably the first 10 years of my practice, that's what we gave for pain. We gave Demerol and Phenergan. We gave some Nubane every now and then. Nubane is kind of seeing a resurgence. Okay, it's a good it's a good drug too. It's a narcotic, but we just don't use as much Demerol. I probably gave like gallons of Demerol it treated everything. And it's funny how it just kind of has fallen by the wayside. But it is an analgesic, causes sedation. But again, you got to make sure that they're not falling, and you got to do your safety precautions. But if I got pain, I want to be lightheaded and dizzy. Thank you. Morphine is usually our first line now. Morphine used to be the stuff that we gave when nothing else worked. That was before we had the fentanyl and all that business out there. But morphine was and then Dilaudid, only terminal CA people got Dilaudid. Yeah, now we get it. Well, there ain't no need in hurting, So morphine is really our first line now. Have to be careful with morphine, though. Morphine is can really cause respiratory depression. Blood pressure can drop. And you can just have a complete circulatory collapse if you give it too fast. Okay. So you think about you've got a post-op patient that is coming out of surgery, and their respiratory status is already compromised because they've been put to sleep. So you have to be really careful with your morphine. Don't withhold it, but you got to make sure that you're not making their respiration zero. I had a lady one time that okay, so use your judgments when you're giving these things. Fentanyl is a new one, that fairly new in my practice that we're giving. It works really well. It is used as an adjunct for general anesthesia and regional anesthesia, which we'll talk about those. Okay. Some of your anticholinergics, these are medications that we give to decrease secretions, oral, respiratory, and some GI. Okay? It also prevents bradycardia. When you start to learn about cardiac rhythms and rates and cardiac medications, atropine speeds up the heart rate. We give atropine for bradycardia. But in this case, we're giving it as an anticholinergic to drive secretions. Your patients usually will have dilation of the pupils, and their pupils don't accommodate when they've had atropine. They have these big old wide, goofy looking pupils. They look snockered. Okay? That's the medical term. Did y'all know it? Don't look it up in Tabor's, but I'm sure it's there. Snockered. So atropine we also use Robenal, which is a synthetic one. I'm not concerned that you know it's synthetic. But it does the same thing. It inhibits secretions. We use a lot of Robenal. And there's your scopolamine patch, too. Sometimes your medications will be like morphine 5 and Robenal 0.2. You have to mix them and give them. Depends on your order. Your benzodiazepines are next. These are the fun stuff, okay? These are the ones that are sedative effects, okay? They induce amnesia. You guys will get a lot of Versed in your careers. It's a mainline drug right there, okay? And it works wonders. Versed, Valium, and Ativan. Some patients will be prescribed Ativan to take by mouth the morning of surgery before they come to the hospital if there's some issues with anxiety and stuff like that. Okay. Your GI meds, why am I concerned with GI meds? Right, because nausea and vomiting is one of those complications, and we see quite a bit of it after surgery as a result of the anesthesias. So we're going to maybe give some of that pre-operatively. Maybe some antacids, not used a whole lot, but it can be used. We use a lot of the IV stuff, okay? The histamine H2 receptor antagonists, which decrease acid production, your Tagamet, Pepcid, Zantac, and we'll talk about these a little more in depth when we go over GI. We talk about peptic ulcer disease. You may one of the things that we really give a lot of now is Protonix. It's a proton pump inhibitor. What it does, it inhibits the secretion of gastric acid. So a lot of patients will just get Protonix pre-op just to, hopefully keep them from having any problems. Okay. People who have surgery, also, especially these really invasive surgeries, and they have kind of a fairly long recovery, they have a risk for ulcer formation. So we give them some of this to aid with that as well. So a lot of your patients will be continued on Protonix post-op as a prophylaxis against peptic ulcer formation. Patients may be given Reglan, which speeds up the emptying of the stomach. You'll give a lot of that too. Okay. It's a prokinetic, but basically it makes the stomach empty. So if you're having to do an emergency surgery, you're probably going to pop them with some Reglan and some Protonix before they have surgery. We probably they haven't taken that day, so we'll give it to them. It won't hurt them. Protonix is given every 12, I think. Don't quote me on that, and I'm certainly not going to test you on that, but I think it's every 12 that gives it. But yeah, that's not one of the ones that we routinely say, go ahead and take that medicine. So other meds that you may see, we've already talked about the antibiotics. What's my time frame for pre-op antibiotics? 1 hour. 1 hour before incision, and we continue them if needed for 24 hours. If we have to go past 24 hours post-op, there should be some documentation on why. If you've got a big, bad, dirty wound that you've had to go in and do a lot of debridement and all that business with, you're going to continue those antibiotics. But again, that's not your call. It's the physician's call. But they have to, and it's their little red wagon to document why they're continuing it. We may give our patient Vistaril. Vistaril is a medication that sometimes you give Vistaril pre-op as an anticholinergic to dry up secretion. It helps with nausea. It's an antihistamine. It's an anti-anxiety medication. And it has a sedative effect. That's just like one-stop shop, ain't it? But you can give it oral or IM. You cannot give Vistaril IV. Some of your surgeries require specific pre-op medications. If you have a patient who's going to have an eye surgery, A lot of times you'll have eye drops that you have to administer within a certain time frame. One type will actually deaden the lens. Another type, because you may give one kind and then wait 30 minutes and put 2 more drops in of another kind. It's a sequence, and it'll be ordered for you. But these eye drops usually deaden the lens, and then some of them dilate the eye ahead of time, so they don't have to wait for that to happen once the patient gets back in surgery. Okay, you may give anticoagulants, usually not, but it's sometimes they're ordered pre-op. Okay, you may have eardrops, all sorts of stuff. Sometimes your patient may have to have a douche before, if it's some type of GI surgery. That's all that's coming to me today. But again, this stuff is going to be ordered for you. So we've done our teaching. We've got the patient hopefully in the building. We've taught them all about pre-op. We've taught them about we're talking about their meds. We've got their consent signed. Basically, your patient is about ready to head on off to the OR. Okay, before they leave your area, there's a preoperative checklist that you need to make sure is done. Every place has one. They all look a little different, but it's the same thing. Okay, making sure that you've done everything you need to do before you send that patient to surgery. There's an example of one in your book, but basically you gotta, it's yes, I've done it. Check, 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 check. Has the patient been NPO as ordered? Has my patient had their pre-operative shower, bath, if ordered? Sometimes patients are ordered to take a bath at home, and then they may be ordered to take another one when they get to the hospital. It's important in our pre-op teaching that we tell them that, and then we also tell them to put on clean clothes. Sleep on clean sheets. Okay? They'll bathe like you tell them to do, but they don't think of those steps. Okay? Clean clothes, clean sheets. Have they had their pre-op hygiene done? Have they been NPO? Do they have their gown on? Have we removed their nail polish? Why in the world am I concerned with nail polish? So I can see capillary refill, so I can get a pulse ox reading, right? Have they had vitals done within 4 hours of the operating room? Yeah, usually when they say on call, you go run and get their vital signs, okay? Are there dentures and false teeth, bridges, partials, plates, have those been removed? Now, used to, everybody had to take their teeth out, okay? But what they're doing now is sometimes anesthesia will tell you to send them to surgery with their teeth in. What happens when you take a person's teeth out? They lose the shape of their mouth, right? So it's a little more difficult to intubate them. So we leave their teeth in so that intubation will be a little easier. Okay, so you just have to ask. If you have to take them out, provide a denture cup, put the patient's name on it. I can't tell you how many sets of dentures that I had to replace because they didn't keep up with them from the time the patient took it out to the time the patient got to go to the house. So dentures are lost easily. Do they have their ID bands on and allergy bands if applicable? If your patients have got blood typed and cross-matched and waiting on them, they may have a blood bracelet on as well. Has their jewelry been removed? Don't send them to OR with jewelry on. Okay, why? It can get lost. Yeah. it's a hazard to them because of lasers and all that stuff. Yeah. It's an infection control issue as well. So we take their jewelry off, and in our pre-op teaching, hopefully we've said don't even bring it. Leave it at the house. Leave your purse at the house. Hopefully we've told them that. But if there's a ring or something that cannot come off, sometimes they'll let you tape it, cover it with tape. Okay. Has the skin prep been done? Okay. Have they been hair removed? Have you scrubbed the site? Depends on, and a lot of times that's done once they get back to the OR. So these are some of the things we're looking at. Has the family been notified? Okay. Sometimes the family's not there. Okay. Is their chart complete? Do they have H&P? Are all their labs there? Consents, pre-ops, all that business. So you got to make sure that they're ready when they roll off of your unit. Another thing is patients are in their gown. You got to get them to take their drawers off. And some little old women, that's a struggle. They don't want to lose their drawers. Okay, so some places are not quite so anal about that now, but cotton and nylon and all those fabrics back in the OR, it can be a fire hazard. Okay, plus sometimes you got to get to that area. So, some of your patients, you just got to make sure that they remove their breeches and that they voided. Have your patient void before you roll them to the OR. Your OR crew will thank you for that. Okay, so remove all the stuff they need, have them void, get their vital signs, make sure their chart is complete, and they're ready. Pre-op them if you're so ready. Okay, that's your checklist. Okay, they may change a little bit from place to place, but that's basically the stuff you want to make sure that you do before you send your patient to surgery. Okay, so transporting the patient to OR. If your patient is an inpatient, most of the time OR comes around, picks them up on a stretcher, and rolls them back to OR. Okay? They may take the IV pumps, they may not. It just depends on what your organization does. If it's an outpatient, those patients may go in a wheelchair. They may allow the patient to walk. Now, if they've been pre-op, they can't walk, because that's just an accident waiting to happen. But sometimes if it's a child, they'll let mom and dad carry the child to OR with the nurse, and then they have to give it up at the door. That's tough. That's tough sometimes. But that just lets the kid have a few more moments of feeling safe. Okay, so there's different ways, and you have to just adjust that transport based on your patient, based on their abilities. Okay? They may even let them walk. So, you tell me, pre-operative, just up until this point, what are your primary nursing diagnoses? And I don't care if you're stating them in NANDA verbiage, just I want to know that you know what you're talking about. At this point, it's a risk for, right? Risk for impaired skin integrity. What's your two main problems? You told me at the very beginning. What did you tell me? That was hours ago, wasn't it? Patient safety, and what's their problem? Knowledge deficit. Your main, really there's three. The main one is knowledge deficit, anxiety, and safety. They have a lot of risk when we're talking about the procedure itself, but at this point in time, my problem is I'm nervous and I don't know anything. So your function in the pre-op setting is to make me feel better, to give me the knowledge that I need, and to make sure that you've identified the risks for complications that I have, and you're working toward reducing those risks. Okay? Related to the surgical procedure, absolutely. Yeah. Okay. Does that make sense? Are you with me so far? Okay.